Good morning, afternoon and evening. I'm Judy LOWTHIAN. I'm the Head of Research at Bolton Clark, and I'm joining you from Melbourne, Australia. This symposium is going to focus on how Bolton Clark continued to deliver our usual health and care services while also trying to optimise wellbeing throughout the pandemic. I begin by acknowledging all Aboriginal and Torres Strait Islander traditional owners of country throughout Australia, and I recognise their connection to land, sea, culture and community. I also pay my respect to elders past and present and extend that respect to all Aboriginal and Torres Strait Islander people. Bolton Clark is Australia's largest not-for-profit aged and community care providers. We're located in almost every state and territory, and we support people in later life in their homes, in retirement living communities, and in residential aged care homes. Now, our work is driven by our purpose, which is to help everyone live a life of fulfilment. And we do this by treating our clients, residents and families with dignity and respect, by acting with empathy and integrity, and by understanding and responding to individual needs, as well as continually improving what we do via insights, research and innovation. In our research, we collaborate with all stakeholders, including our clients and families and our frontline staff, to co-design our projects that either create or modify models of care prior to implementation and evaluation of effectiveness. Now, all of our research is underpinned by the philosophy of positive ageing, with the intention of supporting and enabling people to live that life of fulfilment, whether it be in the community, a retirement village, or in a residential aged care home. Now, all of us here today have experienced the challenges imposed by the COVID-19 pandemic across aged and community care. The infection prevention measures, including lockdowns, masks, and social distancing, were absolutely essential to reduce transmission of the virus. But they did come with unintentional consequences for the health and wellbeing, particularly of older people. So while Bolton Clark continued to provide 24/7 healthcare, we also set out to support those additional health and social needs during this period. Every part of the business came together and worked together, and we transformed existing programs, and we also co-designed innovative new ones to optimise health and wellbeing throughout the pandemic. My colleagues are now going to present some of our COVID-19 initiatives. Linda SCHNITKER is going to talk about the enhanced resident protection measures. Elizabeth Robinson is going to talk about how volunteers provided social support and also an innovation tournament. And Georgina Johnson is going to talk about the health promotion activities. So Dr. Linda SCHNITKER is an academic clinical nurse researcher who holds a conjoint research fellow position between Bolton Clark and Queensland University of Technology. Her research focus includes dementia care, delirium, care of older people, and quality improvement. Elizabeth Robinson has been working with the Bolton Clark Research Institute since graduating from the University of Melbourne Psychology Honours Program in 2019. And her research revolves around preventing isolation, loneliness and depression in older people by implementing programs to increase social connection. Georgina Johnson is a research officer within the Bolton Clark Research Institute, and Georgina has an honours degree in psychology. Her research concentrates on supporting the psychosocial wellbeing of older people and their carers. Thank you.
As Judy just stated, just like other countries, the COVID-19 pandemic created extraordinary challenges for the residential aged care sector in Australia, including our organisation. This presentation about managing COVID-19 in the residential aged care. Our primary aim was to prevent the entry and/or the spread of COVID-19 in our residential aged care communities. We wanted to keep everyone safe, our residents, volunteers, the visitors, and our staff. As Winston Churchill said, never let a good crisis go to waste, Bolton Clark has a strong tradition surviving in challenging times. We learned many lessons from previous infections outbreaks in the past, and we also apply infection prevention and control measures in our everyday practice while caring for our residents. This picture shows nurses delivering service when the Spanish flu pandemic hit Australia in 1919. And similar to COVID-19, the Spanish flu was an airborne virus and highly contagious. We also supported clients with HIV in the earliest of the AIDS epidemic and dealt with outbreaks like flu, swine flu, SARS, and MERS. We also have infection and control measures in place to protect the residents from common communicable diseases, such as gastroenteritis. However, this time it was a new virus. We knew from the start it was a respiratory virus, and therefore we had to learn quick and make decisions based on evolving evidence. On the 11th of March, the World Health Organization declared the COVID-19 pandemic. However, as early as February 2020, our organization developed the Enhanced Resident Protection Measures strategy, and these multi-component measures were fully implemented by March 2020, and all informed by evidence and global reports. The strategy includes 32 different approaches to prevent the entry and minimize the impact of COVID-19 in our care homes, and underpins the following key principles. Staff represents the highest risk of infection transmission to our residents. Immediate family are essential for holistic care, and the total number of people in the care environment required vigilant management. Screening and decontaminations of our residents, our staff, visitors, suppliers, and contractors, and making changes to rostering practices, the use of personal protective equipment, PPE, and the development and implementation of clinical practice guidelines related to COVID-19. Screening and decontaminations. We followed all applicable state government restrictions and directions. We had a clinical nurse consultant coordinating and managing the processes concerning infection prevention and control. Our clinical nurse consultants were effective leaders who advised, motivated, and mentored care staff. We applied environmental hygiene. We set up regular cleaning and disinfect schedules, including cleaning of often touched surfaces and the cleaning of general surfaces. We created and distributed education materials on infection prevention, for example, about respiratory hygiene, cough etiquette, effective hand washing, sanitizing, for staff to stay at home if they are feeling sick, social distancing. These education materials were designed so they were understood by all relevant stakeholders, including our residents, their family members, and contractors that come often to our communities. Our clinical nurse consultants were relevant to inform policy and instruct staff how to safely manage healthcare waste, and this depending on the status of COVID-19 exposure of the site. We screened all people living in, working in, or visiting the home for exposure to and from COVID-19 by using assessment questionnaires and by measuring the temperature at entry of the home. We screened our residents for COVID-19 symptoms to early identify and manage, and also to prevent the further spread of COVID-19 into our homes. All residents' vital signs were daily measures, and if there were deviations, medical input were pursued. We closely collaborated with local general practitioners and hospitals. When rapid antigen tests came available in Australia, we started the surveillance program for all staff and the visitors of the home. Depending on the circumstances, options for separating those residents who screened positive for COVID-19 from other residents that tested negative or were not sick from COVID, including off-site or on-site cohorting of residents. We divided the exposure of COVID-19 in 3 categories, as you see here on the slides, the green zone, amber zone, and red zone. So first, the community exposure only. So there were no positive cases for staff or residents in our care homes. Exposure sites when there were a positive staff member, but no residents. And then red, an outbreak site in which there was a COVID-19 positive resident. Depending on the category, appropriate infection prevention and control measures were taken. For staff, again, we knew that staff represented the highest risk of infection transmission to our residents. It is important to know that in Australia, there's a workforce shortage in residential aged care that presents a significant challenge for the aged care industry in general. But the pandemic created a shift from registered staff working in aged care to better paid immunization nursing jobs. The enhanced resident protection measures included strategies that affected staff and were all driven by upstream approach to identify modifiable factors in the chain of the COVID-19 transmission. For example, the stand-down arrangement for international travel for our staff. Again, screening for all staff for COVID-19 exposure and symptoms of COVID-19. The identification of high-risk living, transport and work arrangements for staff. We provided advice for staff to stay safe while at work and advised them about high-risk activities outside of work that placed our residents at an increased risk of getting a COVID-19 infection. Some staff had multiple jobs and worked for other aged care providers, and therefore there was an increased risk of bringing the virus to our organization. Some solutions included no dual employment allowed, a dedicated bus for staff to travel to and from work, and accommodation for employees living in at-risk environments. And we also changed our rostering practices. PPE for COVID-19 includes masks, gloves, goggles, face shields, gowns, and aprons, as you see here on the picture. There is a national medical stockpile in Australia, which is a strategic reserve of certain medications and vaccines, and also for protective equipment for the use in national emergencies. However, there was a national supply issue for PPE in Australia. We really prepared for the worst case scenario where there wasn't any PPE for us to utilize. What happened if we can't get any glass? What are the alternatives? Luckily, it didn't get to that point. Initial actions across the organization ranged from procurement teams, sourcing and purchasing additional PPE. The quality of the PPE was an issue. We were testing our stock, and as we were buying from suppliers who were unknown to us. We also ensured we had enough oxygen, we had enough medications, thermometers, oximeters at each site. Additionally, we had to train the workforce, but also visitors, how to don and doff a PPE and how to dispose the equipment. Training happens very quickly through our secondary business Altura Learning to produce COVID-19 related training courses for our use and for the use across the industry. And this was supported by additional training and the appointment of infection prevention champions at each aged care home. Since our residents are at a greater risk of severe illness from COVID-19, once the vaccines were available, and that happened in March 2021, we organized vaccination clinics on site for residents. Also, aged care staff were early eligible to get the vaccines. In the end, 100% of our staff were immunized. After the injection, we monitored our residents for side effects. We kept monitoring their vital signs daily to early identify and manage potential side effects. We also kept track of whom was vaccinated and the number of shots they had received. Also, vaccination and check-in requirements for visitors at sites were and are still in effect, meaning the staff are required to check the vaccination statuses of all visitors. With the focus on the COVID-19 vaccines, we also ensured our residents did get their annual flu jab. We already had strong procedures in place. However, we made significant changes to our clinical processes concerning this new virus. Our services are built on experience and insights and are strengthened by our teams of senior clinical nurse advisors and clinical nurse consultants and our researchers from our research institute. For example, to inform policy and practice, our research were searching the evidence twice weekly concerning the international COVID-19 evidence regarding, for example, the signs and symptoms of COVID-19 in the older population, effective prevention and treatment, or lessons that were learned from Spain and Italy. We were able to build quickly and comprehensive COVID-19 specific guideline. Topics that included, for example, were what vital signs to take and when and how often. COVID-19 screening for residents with symptoms, precautionary isolation, how do you do that? How do you cohorting of residents? Thinking about isolation zones, or for example, when to transfer a resident to the hospital. To prevent the spread of COVID-19, there were visitors restrictions to our homes, and there were also government-directed lockdowns. This was positive because we could prevent the entry and the spread of COVID-19 in our homes. However, the downside was that it was challenging to meet the social needs of our residents, the need for belonging, connection, and friendship. We stressed in our approach that social connection is important. We organize, as you see here on the pictures, virtual meetings with residents' family members, window visits, and ensured that we continued offering meaningful activities. We implemented the Essential Partner Program for the resident significant person who was able to visit and support the resident during lockdowns. And there were no restrictions on the time and number of visitors for residents who were at end of life. Strong leadership was key during this pandemic. Our leaders were adaptive and were informed by our knowledgeable clinical nurse consultants, the clinical governance team, and clinicians who knew exactly what was happening on the ground. The executive team gave those people a voice in the types of decisions that they had to be made to ensure we reach our primary aim, and that was to prevent the entry and or the spread of COVID-19 in our aged care communities. And as today, this is still occurring. Here you see a picture of our executive general manager supporting care staff at site. Our Bolton Clark enhanced resident protection measures were successful in protecting our residents for the impact of COVID-19 and were shared nationally to assist small aged care providers. During the pandemic, our regular consumer experience survey found overwhelming support for our measures, with 98% of residents responding that they stayed connected with family and friends, and 98% being satisfied with our pandemic response. I think all stakeholders involved knew that this was and still is a challenging time for the aged care industry. I'd like to acknowledge all our staff in Bolton Clark, especially the people on the ground, for their hard work and dedication to ensure our residents can live a life of fulfillment, and also during challenging times. So really thumbs up for them. I'm very proud of our organization. I now hand over to Elizabeth Robinson, who is going to talk about how COVID impacted the mental well-being of our clients in the community and the approach Bolton Clark took to address this. Thank you.
Thank you, Judy and Linda. My name is Elizabeth Robinson, and I'll be telling you about how Bolton Clark maintained social connection during the pandemic through rapid implementation of 2 programs. Let's start with the opposite of social connection. What are social isolation and loneliness? Social isolation is a state of having minimal contact with others. It can be objectively measured by counting the number or frequency of an individual's contacts. Loneliness, however, is a subjective feeling in response to having lower levels of social contact than desired. It's an emotional response. You can experience social isolation without being lonely, or feel lonely while being well connected, but the 2 concepts are often highly correlated. Loneliness and isolation are associated with many poor outcomes, and in fact, health outcomes associated with loneliness are on par with the impact of smoking. Prolonged periods of isolation and loneliness are associated with mental health issues, such as depression and anxiety. Social interactions require many neural connections, and are cognitively complex, often involving memory, comprehension, generation of novel topics of conversation, humor, and empathy. As such, staying socially connected is a good cognitive workout and is preventative for dementia, frailty, and functional decline. Loneliness and social isolation are also associated with poor physical health outcomes, such as high cholesterol, high blood pressure, cardiovascular disease, stroke, and early mortality. Prior to the pandemic, there was already a high prevalence of both social isolation and loneliness in older populations. We often find significant reductions in social networks during older age due to retirement, changes in family dynamics, and death among social contacts. In Australia, as in many other countries around the world, government-mandated restrictions have been an effective tool for reducing the spread of COVID-19, including stay-at-home orders, social distancing, and limitations on gatherings. These measures, designed to prevent the spread of COVID-19 by keeping people physically apart, have also made people more socially disconnected. I'm presenting to you from Melbourne, Australia, where we underwent the longest and most restrictive of the Australian lockdowns. We spent a cumulative total of 263 days in lockdown, which at the most restrictive involved only 4 reasons to leave your home. These included an hour a day to exercise and shop for groceries and medicine within a 5-kilometre radius of your home, attending authorised essential workplaces such as supermarkets or healthcare, and attending medical appointments, getting tested or vaccinated against COVID-19, or providing care. Other Australian states had varying levels of lockdown and restrictions depending on the spread of the virus in each state. These included social distancing measures in residential care facilities, many of which Linda has already outlined, including restrictions on visitors and confinement to specific areas of the home to prevent spread of the virus among the most vulnerable before the vaccine was made available. People in the care of Bolton Clark in the community also tended to self-isolate because they're particularly vulnerable to the virus. They're not only older, but they're using our service precisely because they have health conditions which require expert nursing and personal care. Many of our clients and residents rely on us not only to provide health services, but also some social contact and interaction. As individuals moved to limit their risk of the virus, many reduced or suspended their services, further isolating them. These restrictions and the impact of living through a pandemic generally affected the population Australia and worldwide, with levels of negative emotions 3 times greater during the pandemic than existing Australian population norms, and similar findings in Europe and North America. An Irish study of older people who were self-isolating found 40% of participants reported worse mental health since they started isolating, and people in residential living also experienced declines in their mental health, with nearly half surveyed experiencing loneliness and a third experiencing anxiety. To rapidly respond to this growing issue during the pandemic, using a top-down approach, Bolton Clark implemented the evidence-based How Are You telephone support program, providing a way to maintain social connection in the community while staying distanced. This program is built on a pilot project led by Professor Judy Lowthian within emergency departments, in which hospital volunteers provided weekly telephone support for 12 weeks and then connected participants to community services. The program achieved feasibility and acceptability, and participants experienced significant reductions in loneliness and depressive symptoms. When the pandemic and related restrictions arrived in Australia, Bolton Clark seized the opportunity to pivot this evidence-based program to our isolating community members. Our program involves weekly social calls from a friendly volunteer for 12 weeks, and it's hoped at the end of the 12 weeks, the volunteer can help connect the participant to any available community programs, but many of these were stopped during the pandemic. To reduce the potential workload on referrers, no formal screening was undertaken. Anyone suspected to be experiencing isolation or loneliness from the Bolton Clark community and our partner tertiary health services community programs could be referred and receive calls. Volunteers were sourced from Bolton Clark corporate staff in a newly established corporate volunteering program, as well as our partner health services existing volunteers who weren't able to go into the hospital to conduct their usual volunteering and enjoyed an opportunity to volunteer in another way. It was hypothesized that How Are You would lead to reduced feelings of social isolation, loneliness, and depression, an increased sense of belonging and self-worth, and all-round improved health and well-being, as well as reducing health service use associated with social isolation and loneliness. Rapid implementation of the How Are You program involved co-design and consultation with people across both organisations during the early months of the pandemic, creation of volunteer training materials and a system to manage the program, development of governance pathways to ensure the safety and well-being of volunteers and participants, recruitment of corporate volunteers, and ongoing program monitoring by gathering feedback from volunteer call logs, which were completed after every phone call. Our first call occurred on June 23rd, which was 3 months after we went into our first lockdown. In the following 18 months, we received 227 referrals and enrolled 158 people in the program. 83 volunteers have joined the program, been trained, and made 1,285 calls. These social calls are an average of 24 minutes long, with participants usually wanting to talk about their family, the weather, and current events. 69 eligible How Are You participants were invited to complete pre- and post-program surveys over the phone, which included validated measures of social isolation, loneliness, and depression. People who didn't want to participate in the research were still able to receive calls. 23 people consented to take part, with 14 surveyed post-program. We found a 25% reduction in social isolation, a 3% reduction in loneliness, and a 33% increase in depression. However, it's highly likely that these results were influenced by varying levels of recurrent lockdowns, experiences of COVID-19, and other restrictions during the pandemic. In addition to the pre- and post-program surveys, we conducted interviews with a random sample of participants and volunteers and surveyed frontline referring staff. All of the surveyed participants reported being satisfied with the How Are You program. One participant said that receiving the calls made her feel good, while another indicated that she could talk about anything with her volunteer and built up a close bond over the 12 weeks of calls. She stated that she looked forward to our talks. I could open up and talk about anything, even referring to the calls as like talking to a daughter. None of the participants suggested any improvements to the How Are You program. Some indicated they would refer friends to the program, with one participant saying they would refer because it's something else other than what you're used to, someone else with different opinions that you aren't used to. A major theme emerging from interviews with volunteers was that the benefit of the How Are You program was not only to those receiving the calls, but those providing them as well, particularly during times living under lockdown and social distancing measures. One volunteer said of How Are You, the value of the program is a lot higher than it appears on the surface. All staff believed the How Are You program should be continued, with many indicating it was a program that fills a gap and would be useful particularly for the vulnerable ones that live alone with limited supports, as social isolation is a big issue. Staff had a few suggestions for improvements to the program that are being considered by the coordination team. The How Are You program is an example of an existing evidence-based program implemented rapidly in response to the growing social isolation and loneliness during the pandemic. This top-down approach to maintaining social connection provided benefit not only to participants, but also to volunteers, and was well received by referrers and the organisation as a whole. It was successfully implemented into business as usual at both Bolton Clark and our partner Tertiary Health Service, and to this day continues to help keep people connected. The second program, rapidly implemented to maintain social connection in residential care homes and villages, utilises a bottom-up approach, seizing the opportunity to generate ideas from the grassroots using an innovation tournament. An innovation tournament is a form of crowdsourcing where ideas are submitted to address a challenge. These ideas are then judged through a series of rounds. They're fun, a low-cost way to engage a community while solving a problem. During the pandemic, we conducted an innovation tournament with our residential villages and care homes after noticing some were already generating innovative ways to stay connected during restrictions. The innovation tournament was across our residential aged care and retirement living streams. Submitted ideas underwent 2 rounds of judging. The first round submissions were a written response to these 6 questions. At each site, staff and residents worked together to submit up to 2 ideas. These ideas could be completely new or something already underway. Each submission in the first round was judged by a panel of care home and village managers, members from the Research Institute, and executives. Submissions with the top 10 scores progressed to round 2, which involved creating a 2 to 3 minute video showcasing their idea. Staff and residents from across the organisation viewed all 10 submissions and voted for their top 3. The winners from each stream were announced and celebrated through our internal magazine, as well as our intranet page. They were also awarded a certificate, a trophy, and had a big celebration. 51 amazing ideas were generated by staff and residents, including intergenerational pen pals, a plant program, an outdoor cinema, and a resident bake-off. But our winners were Bolton Old Boys Brew, a ginger beer brewed, bottled, labelled, and enjoyed by a group of residents and staff, and the Hole in the Wall coffee shop, about which one resident said, "We were all missing our monthly coffee club and happy hours, and to have nothing was awful. But the Hole in the Wall cafe has lifted everyone's spirits." But in reality, all the villages and care homes were winners, coming away with a toolkit of ideas to boost social connection during recurrent lockdowns and social distancing. The residents also benefited from the tournament with increased social interaction between residents, a sense of purpose, a buzz of excitement, and a real sense of achievement. While staff experienced strengthened bonds with the residents, an increased sense of community, belonging, and pride, and staff morale was improved all round. The organisation as a whole also benefited from internal business collaborations, positive media buzz, and something to be excited about during challenging times. In conclusion, we were able to rapidly implement an evidence-based program, How Are You?, and crowdsource several great ideas using an innovation tournament, in the process ensuring that our community, residents, and staff maintain connections during a very difficult, isolating time. Thank you so much for your attention. I'll now pass you on to Georgina Johnston to tell you about maintaining physical health during the pandemic.
Thanks, Elizabeth and Judy. My name's Georgina, and today I'll be presenting promoting and maintaining physical wellbeing in older people during COVID-19 lockdowns. And I'd like to start by acknowledging that this program and much of the work I'm presenting today is only possible due to the tireless and enthusiastic efforts of Kerry Randell, National Program Manager at Bolton Clark. So as my colleagues have mentioned, and as many of us have lived through, the COVID-19 pandemic and associated restrictions not only impacted on the social and emotional well-being of older people, as Elizabeth mentioned, but for many, it also greatly impacted their physical activity. People were no longer able to partake in their usual physical activities, such as going to the gym or playing sports. They reduced their visiting of public parks or recreation areas, as well as their participation in community activities. And as a result of this, people's physical well-being suffered, notably in the older population, demonstrated through increases in frailty and rates of falls. And this was only compounded by the inability, reluctance, or fear of attending usual or required healthcare, as well as a drop in engaging in health promotion activities that weren't directly related to infection prevention or control measures. And it also happened that many community-based organisations were forced to alter or cancel their usual health promotion programs. So how did this affect us at Bolton Clark? We have a long-running and award-winning Be Healthy and Active preventive health program that aims to help keep older people staying independent at home for longer. It provides practical information on how to maintain health and well-being. And these free sessions have been running since 2016. and are normally 1 hour presentations delivered nationally to community groups in community settings. And over this time, the program has delivered 950 sessions to over 26,000 older Australians nationwide. And the topics range from skin health, bladder health, first aid, and understanding dementia, just to name a few. And they can be delivered in languages other than English. So as you can imagine, in 2020, physical distancing and restrictions challenged us to rethink how these sessions could be provided. And this led us to take 2 different solutions. So firstly, what did we do? In collaboration with Ultra Learning, we produced 5 10-minute condensed health and wellbeing videos, 4 of which were based on the original sessions we ran, and we developed one new one to meet need, which was managing sleep and fatigue. And the challenges that we faced with these videos were delivering them quickly, during a lockdown, on a really tight budget, and having to use production techniques that abided by social distancing requirements. So we went with a very simple presenter to camera style of shooting with minimal people on set. We also needed to condense the usual 60-minute interactive face-to-face sessions into only a 10-minute engaging video, whilst keeping the language really understandable and in plain English. We spent considerable time on the script, following the Bolton Clark Health Literacy Guidelines. And during this process, we were fortunate to engage some of our target older population remotely, which allowed us to make changes and improvements to our script and videos to best meet their needs. So with a lot of hard work from everyone involved, we went from a concept at the end of March 2020 to the final product being on the website with all the accompanying resources in just 10 weeks. So to do this, we had to take an organisation-wide approach. We drew on the skills and expertise of staff right across Bolton Clark, from our head of research, Professor Judy, who you heard from earlier, some research fellows, our principal advisor for wellness and reablement, a clinical nurse consultant, a district nurse, a human resources staff member who is also a yoga teacher, and one of our brilliant chefs from our central catering team. And these are the 5 videos that were produced, namely falls prevention, healthy brain, healthy body, managing sleep and fatigue, master your mind, and healthy eating and nutrition. And as I noted, the purpose of these videos were really to support individuals' health and well-being during the pandemic and help them to take on elements of their care that would not otherwise be monitored by a health professional or members of their support network. Each of these videos were made easily available for free on the Bolton Clark website, and we also provided copies on DVDs for distribution in our retirement living communities. Now, on the Bolton Clark website, accompanying each of the videos are resources that we created and redeveloped with this health literacy lens in mind. And we also provided links to other helpful sites. So to give you an idea of how this looks, I'm going to run you through our most popular video on falls prevention. And this covers the main risks of falls, the importance and benefits of staying active. It provides 6 strength and balance exercises demonstrated by a physiotherapist, and importantly, how to get up if you have a fall. And accompanying these are an extensive list of resources, including our own home safety checklist and a printable exercise list with picture demonstrations. And you can access all of these videos and resources for free on the Bolton Clark website at boltonclark.com.au/behealthy. So that was the first approach we took. But our second approach was to trial online or virtual sessions. We started off with Healthy Bladder, aligning with World Continence Week in June, and we were overwhelmed by interest. And it was this strategy we continued to use, timing our talks with the major health weeks, with Healthy Skin around Wound Awareness Week, and Understanding Dementia in September alongside Dementia Awareness Month. Over the first 6 months from June to December 2020, there were 60 virtual sessions booked in, and over the 2 years, almost 100 virtual sessions were delivered to over 1,400 older people. And as you can understand, in the pandemic, the most popular sessions were related to managing stress. And we found that these online talks have been a great platform for keeping people connected and informed, and have also allowed us to broaden our audience, extending our reach to regional and remote communities we couldn't previously reach. Now, at the end of each session, we like to ask participants to fill out a feedback form as part of the ongoing evaluation. Our participants remarked how convenient it was to take part from the comfort of their own home, how relevant and informative the sessions were, and how engaging the presenters were. And despite a few teething issues, the technology worked pretty well too. And it facilitated people attending or even presenting who normally wouldn't be able to in person. And I want to share the feedback from one participant, Mary, who noted, "I'm very pleased to have joined this session through my community group. During this lockdown period, I've found myself very stressed. This session has given me ideas to help myself." And coinciding with this period of going online was the introduction of a new evaluation process, where we added new evaluation questions to the feedback form designed to measure participants' knowledge post-session. And we didn't design this as a test with any trick questions, but rather as a knowledge check that allowed us to see what information was being absorbed so we could tailor our delivery of information if required, but also acted as a great way to prompt and reinforce participants' memory and actions on the key areas we thought were important. And on the screen is an example of what we developed for the two of the sessions, the falls prevention and master your mind. And you can see it worked pretty well. And participants are also asked if they agree to a follow-up survey in 3 months' time, which measures knowledge and any behavioural change that is sustained after the session. And this data is currently being analysed. So in conclusion, the Be Healthy and Active program continued to provide practical and accessible education in the community during the COVID-19 pandemic. It also provided great opportunities for older Australians to stay connected during this challenging and potentially isolating time amidst lockdowns and restrictions on gatherings. So where to next for the Be Healthy and Active program? We think that the hybrid model will continue into the future, with the mix of face-to-face and online opportunities helping more people from further across Australia engage with living a life of fulfilment. We've learned that the key to success are having the right presenter, as is the language and tone of the content. Older participants loved the humour and personal stories interspersed with the informative content and opportunities for questions, all delivered in a way that was engaging and not overtly medicalised or critical. And secondly, that health promotion in the community is not just about the transfer of information and learning, but that the opportunity for connection with others that it provides is just as valuable. And I want to leave you with this beautiful feedback received from the group organiser recently after the first face-to-face session back at the Springvale Indo-Chinese Mutual Assistance Association after a 2-year hiatus. And they said last week everybody was overjoyed to see the group back and enjoyed the session after almost 2 years. You can't imagine how happy they were last week. It's very emotional, and I now know how important it is to have activity like this in our community. So I want to thank you for listening today. And I also want to thank again Kerry Randell, Be Healthy and Active Program Manager, and all the wonderful Be Healthy and Active presenters, without whom this program wouldn't be the success it is. I encourage you to please take some time to check out the resources on the Bolton Clark website. So to conclude this symposium, as Winston Churchill famously said, never let a good crisis go to waste. COVID-19 has been a real test globally, but it's also shown how communities around Australia and around the world have been able to come together to support each other. In this symposium, we've shared some of the challenges and benefits of launching new programs and repurposing existing programs during this time at a national scale. And this for us is evidence that community and aged care can pivot during a large-scale health crisis, not only to continue providing health care to our clients or residents safely, but also to support additional health and social needs throughout this time. And this was only made possible by drawing on resources and capacity from within all levels of the organisation, as well as partnering with others. And this had to be facilitated by clear communication and collaboration. I want to thank all the presenters from the Bolton Clark Research Institute who presented or contributed to the work today in this symposium, the broader Bolton Clark community, as well as the IAGG for allowing us to speak about our experiences today. And at this stage, I'd like to open up for questions. Thank you.
There's a few questions popping up in the chat. Linda, the first one I think we'll give to you. Since the introduction of those enhanced resident protection measures has happened, what has the impact been on infection control practice? Has the effect been sustained?
Yes, absolutely. I think at the moment we are masters in infection prevention and control, especially in like microorganisms that transfer via droplet airborne. So I think the other thing is that we know how to use evidence and translate it into practice. I think we had to move quickly, and it's quite interesting how quickly we have adapted all those new evidence that came from overseas that we use in the Australian context. Yeah, absolutely.
Oh, fantastic. And how about the families? Have they sort of still maintained their ability to remain vigilant upon entry to the home and things? Because I gather it's been pretty tough.
Yes, that's still happening. Like the visitors are screened at the door still, red tests to identify whether they are COVID positive. It is to protect our residents. We want to keep our residents as safe as possible. And everyone sees the needs to do this. Yeah.
Well, that's fantastic. Thanks very much, Linda. Next question. I think this is for you, Georgie. In terms of all those wonderful programs that Be Healthy and Active had, were there any others suggested as a result of all of that activity that went on? You know, are there any other topics or are there any other plans?
Yeah, we're always looking, and particularly in Kerry, always looking for new programs that can be run. We really value the feedback of all attendees who give us great ideas about what they want, and the sessions are really driven by the needs of all of the people who attend. We want to make sure it's relevant to them, it's meaningful for them, and it helps them to stay engaged with their health and well-being. Really excitingly, we've just run a health and wellbeing survey in 25 out of our retirement living villages, and we've found some really interesting areas of need that haven't necessarily already been met by the existing Be Healthy and Active programs. So in things like mobility aids, aids around the house to help independence, perhaps home modifications, and we're also looking to tailor some of our existing programs. We know that there is quite a challenge throughout the whole global community around cost of living at the moment, but this is particularly pertinent to older people. And in speaking to some of our retirement living managers, they've really identified that we need to adapt our programs to meet the current needs of these individuals living under financial pressure, particularly in terms of nutrition and food security, and thinking of ways that we can do cheap, affordable, yet nutritious meals, and engaging the staff that we have. We've had one great village manager take the initiative to invite a chef to come in and run one of the sessions. And it's that engagement that really drives where the sessions are going forward, as well as the support of all of the sponsors that allow these sessions to run. So we're always looking for new partnerships. We're also thinking things like digital literacy, we know is really important. and stuff around sensory loss, so vision and hearing. And we think they're all really important areas that we want to work together with older people in the community to find out what matters to them and how we can design sessions around their needs.
Well, that's fantastic, Georgie. And in terms of the sessions, you know, I understand that Bolton Clark has got retirement villages and communities all around Australia. How do you supply the speakers and the facilitators of these sessions? Do you fly people here, there and everywhere, or?
No, we think it's really important to draw on the local existing communities. It's really important to have someone that people trust. So we've been lucky enough to draw on some of our at-home support staff, so our clinical staff, our allied health staff, to be able to run some of the sessions, particularly physio. So we've had physios running our falls sessions. We've had individuals with expertise, but we have also had to bring people in. But we love having our own Bolton Clark staff run these sessions. We can also run them remotely. I mean, that's one of the great learnings we've had, is the ability to wirelessly provide expert speakers from Melbourne to shoot all the way up to Brisbane in, you know, via the magic of the internet. But we're always looking for ways. We know that our staff have incredible skills that they want to share. So we're always looking for new partnerships or new staff to be able to run these sessions.
That's fantastic. And so since the pandemic has settled down a bit, is the mode of delivery largely virtual over the net, or are people starting to get back together again?
I think people are starting to get back together again, and maybe this is something Liz can perhaps speak to. We've noticed that there still is hesitancy to re-engage in communities after the COVID pandemic. The restrictions, while necessary, did have a really big impact on social connection, ability to go out, and we know that there's still quite a bit of fear in the community around going out, catching COVID or influenza, and the impacts that that might have. So we know that there is a lot of people who are still not quite willing to come out to these group sessions yet, which has meant that they haven't quite had the impact. So having that virtual or online option is also a great one to have in our back pocket.
Fantastic. So Liz, I'll cross over to you now. You know, you talked about How Are You, this volunteer delivered program. Who were the volunteers? Where did you get them from?
Yeah, I actually think the volunteers were one of the best aspects of pivoting the program, because we wound up using volunteers from our partner service who were not able to enter the hospital at the time, so it gave them the opportunity to continue volunteering in a slightly different way. But we also engaged with corporate staff at Bolton Clark, people from people and culture, human resources, same thing, finance, IT, even our executives and our CEO all volunteered to make calls, which was such a great opportunity for everyone in the office, because it not only gave them an additional social connection during a difficult time for everyone, but it also gave them a connection to the people that we help at Bolton Clark. You know, sometimes you're working in an office and you don't necessarily get the chance to meet the people that you're helping from behind the curtain. And it was one of the things that we heard about a lot, was people were really appreciative of being able to talk to our clients.
Fantastic. And as Georgie suggested just before, people are a little bit fearful about re-engaging with the community. Are you still offering the How Are You program? Is there a need for it, or is everything fixed now?
You know, we absolutely are, because even before the pandemic, 1 in 4 older Australians reported being lonely. It was an issue prior to restrictions, and it will continue to be an issue. I think one of the big things coming out of the pandemic is a lot of people have lost, they're fearful, but they've also lost their incidental social connections. And they're hesitant to re-engage with the community. And additionally, a lot of those supports and focuses on social isolation and loneliness that were in place while we were under lockdown have kind of been pulled away a little bit. There's an assumption that people are able to engage with the community themselves. There's an assumption that everything's back to normal and people are doing okay. And in a lot of cases, it's not the case. You know, there are people who still really appreciate the program and really need it. So we continue to offer it both at Bolton Clark and at our hospital partner.
Fantastic. And what other effects, I'll open it up to all of you, what other effects has the pandemic had other than social isolation and loneliness on vulnerable people? Has it affected them in any other way other than disengagement?
I think that's been a really interesting, conversation around stigma towards older people in the community. Often, I know across different countries, there was a lot of different ways in which older people were portrayed as being incredibly vulnerable, which in many cases medically they were, but it did portray individuals in quite a negative light. And it also had an impact on. So I think there was quite a lot of negative rhetoric out there around older people, and I know there's a huge campaign to fight that ageism and even self-ageism that older people have internalized throughout the pandemic, when the messages that they're hearing are older people are going to die from this and it's inevitable. And I think a lot of older people felt incredibly scared. They felt incredibly undervalued in that context, and I think that's going to take a lot of time to undo, on top of the long-term ageism that was already in place prior to the pandemic.
Great, thanks, Georgie. And Linda, in terms of the residential aged care homes, with the older people, obviously they were locked in their rooms and things. Has that had an impact on general health and wellbeing other than feeling lonely?
Oh, absolutely. Thinking about indeed the connection, but also the physical function of people, like being out of their routine, what they normally do, going for a walk or going outside, or it all has changed. So it all impact on physical well-being and also mental well-being. Yeah, absolutely.
And I would imagine with a lot of people with living with dementia, that would have more ramifications because they're out of their routines.
Yeah. Oh, and also like the interpretation for them, if somebody, certainly a staff member, is wearing PPE, how confusing that can be, and to explain what is happening. In the context of the REC, but also in contact with the world. That has been
fantastic.
Hard, yeah.
Okay. Well, look, thanks very much, ladies. It was a great symposium that you delivered, and some fantastic questions from our audience. So I think we might just thank everyone for their contribution.
Thank you.
Thanks, guys.
Thank you.